Hi, this is Dr. Ferguson, and today I'm going to talk to you about 10 tips for preparing for Journal Club. Special thanks to Cole Honeyman, Brixton Mellinger, and Delaney Miller for helping me assemble these useful tips. They learned some of these firsthand in their first rotation experience with me. Tip number 1. Thoroughly research the disease. First and foremost, make sure you're aware if there are current clinical practice guidelines for the topic that you're presenting. And if there are, make sure you can start to understand where this drug therapy might fit in the context of other treatments. Would it be a potential first-line option? Why? Is it a last-line option? So what additional benefit does this drug have to already established treatments? For example, if your article's on the topic of depression, make sure you understand what other treatments we have and how this drug therapy might be better than existing treatments. Tip number 2. Assess for bias. Bias is anything that weakens the accuracy of the study results, or the ability to establish if it was the drug itself that resulted in the outcome. This is internal validity. Techniques like blinding, randomization, having a control group, ensuring correct dosages were used, ensuring outcomes were objectively assessed, all of these strategies reduce the opportunity for bias. This is why the study methods are so important to the internal validity of a study. Bias can also be introduced through the source of funding. So it's important to know who funded the study, and more specifically, what their role was in the design of the study, the collection of the data, analysis of the data, and writing of the manuscript. In this assessment, you also want to look at the conclusions and determine for yourself if they were accurate and truly based on the data that was provided in the study itself. Tip number 3. Appropriately reflect and assess inclusion and exclusion criteria. Do inclusion criteria represent who we would use this drug for? Consider the severity of disease and other treatment options in the context of this assessment. Did the study exclude anybody that would most likely receive this treatment in practice? If so, why? And was it justifiable? Most often, exclusion criteria focus on safety concerns, or in some situations, confounding factors, or variables that might have influenced the outcome itself. Be sure you can thoroughly rationalize all exclusions, because by having too many people excluded, most often you can weaken your external validity. Tip number 4. Consider other factors. How much does the drug cost? And how does this compare to the cost of existing treatments? Does its efficacy justify this expense? Ask yourself, can my patients afford this? Also consider the dosing. Should the dose of either the new drug or even the control have been titrated when it was started? Was it? Should it have been titrated when the drug was discontinued? And if so, was it? Lastly, ask yourself, did the study assess adherence to the drug? How was this done? Because how can we know how well a drug works if we don't know if it was taken as prescribed? Your assessment of these things will not only help you determine the clinical significance, but can also help you with the external validity of the study when looking at dosing and adherence. Tip number 5, we're halfway there. You don't have to be a statistician, but you do need to be able to connect whether the right statistical tests were used based on the outcomes that were studied. You need to look at the outcomes, look at the type of data, assess the study design, and whether or not there were confounders. Words like stratification, covariates, adjusted for, these are all clues that confounders are present, and the statistical analysis will often account for those in the choice of test. Internal validity is improved if the correct statistical tests are used. Remember, it's these statistical tests that give you those p-values and confidence intervals, aka your result. Tip number 6, pull supplemental information as needed. Oftentimes, publications are limited on word space, and so they can't list every method when they write it up. So oftentimes you might see them reference to supplemental information such as a protocol or an appendix. Go to this information when you need to clarify methods or view additional results before you assume that there are weaknesses to the methods. So you can find this on the article website, or you can check registries like clinicaltrials.gov to clarify information. The supplemental materials can offer a lot of useful information, most commonly full descriptions of inclusion and exclusion criteria, clarifications of statistical tests, secondary or subgroup results, etc. Tip number 7. Assess results for both statistical and clinical significance. You have to be able to evaluate a confidence interval. It is the most important way to establish clinical and statistical significance, all within the context of a single result. So remember, something might be statistically significant, but it may not be clinically significant. And a p-value, or a probability value, can only tell you whether a result is statistically significant. So your preference should always be an assessment of the confidence interval. The confidence interval tells you what range of results you would expect to see outside of the studied population. So you really need to look at the full range of these possible results. When the confidence interval is wide, it means that the data is somewhat imprecise and variable. And if it's narrow, it means it's precise. In other words, we have greater confidence in seeing that result in your particular patient. So as a reminder, statistical significance can be established two ways: with a p-value, and if it's less than alpha, alpha is a method. It's typically set at 0.05 or less. It's our risk of accepting a type 1 error or a false positive, so we want to keep that at less than 5%. If our p-value is less than this alpha, it means our result is statistically significant. With a confidence interval, if your results are presented as a ratio, such as relative risk, odds ratio, or hazard ratio, if your confidence interval crosses 1, then the result is not statistically significant. Think of it like this. If you have a fraction and your numerator and your denominator are the same number, it's essentially a ratio of 1, or no difference in the numerator or denominator, no difference between groups. If your results are absolute differences, for example, the difference in results between two groups, then you look for the confidence interval to cross 0, meaning the difference between the two groups at some point might be nothing. This would mean the result is not statistically significant. Tip number 8. Don't ignore tables, graphs, and footnotes. Tables or graphs can really make it easier for you to read and interpret results, and footnotes might give you additional information, such as a clarification of what statistical test was used. It might define abbreviations, or even clarify outcome definitions. How the results are presented can also clue you into exactly how the outcome was captured or assessed. That can also help you understand the choice of statistical tests that was used. Tip number 9, assess for the risk of error. In other words, could your result be wrong? Your first step in assessing whether or not your result could be wrong is the result statistically significant, yes or no? If yes, then essentially consider this a positive finding, but could it be falsely positive? Remember, it's alpha that protects our study from a false positive or a type 1 error. And for a two-sided hypothesis, which is very typical for any superiority study, alpha is set at 0.05. For a one-sided hypothesis, such as in a non-inferiority study, alpha might be cut in half and set at 0.025. If your answer was no, the result was not statistically significant, then you need to ask, could it be falsely negative? And it's power that protects the study from a false negative or a type 2 error. If your result is negative, you need to fully assess the 3 components to power. 1, is power set at 80% or higher? 2, did the study meet the sample size needed to achieve that percentage of power? That's the number of patients analyzed. And number 3, did the study achieve the difference in effect that they expected to see? If all of these answers are yes, then you should feel confident that the negative result means that the drug just was not effective. But if something was a no, in terms of they didn't meet their power, they didn't meet their sample size, or they didn't achieve the difference in effect they expected, then your results might be inconclusive due to a low power. Tip number 10, don't read the discussion. Don't read the discussion and conclusion until you've created your own ideas and conclusions about the study. Remember, the discussion and the conclusion is the author's opinions and interpretation of their study results. By doing this on your own, You avoid always agreeing with what you have read. This is especially important when the funding source could have introduced bias. So the bottom line is, form your own conclusions rather than letting the study do it for you. Students, before I sign off, my last piece of advice is to ask for a practice opportunity if possible. And if you're a preceptor, consider offering a low to no stakes practice opportunity before students are graded on their presentation. The best way to improve your literature evaluation skills are to practice them as much as possible. Good luck and happy presenting!